من Australia. And in light of such an international crowd, I will stick to English for the purposes of this session. Before we start, could I please invite attendees to share in the chat box their names, medical background, and where they're tuning in from? So my name is Dr. Karim Kantar or Karim Al-Quntar, and I will be facilitating this session as a moderator to ensure we run on time whilst delivering our educational content. I'm an orthopedic surgeon based in Melbourne with a practice that's exclusive to the treatment of spinal conditions in both pediatric and adults, including deformities such as scoliosis. Originally, I grew up in Beirut, Lebanon, but my family is from a village called Tain. I'd like to welcome you all from around the world who are attending this session and commend you for your efforts in continuing medical education. I'd also like to thank the Ministry of Public Health, the International Organization for Migration, ALMA, who for facilitating such an international medical community. For those who are unable to attend, we will be recording this webinar and sharing on the ministry's YouTube channel. Please fill in the Google attendance sheet that's been shared in the chat box. And I'm just looking at the crowd here. It's amazing how many people we have. And it's amazing how international the crowd is. And basically at this stage, we have Dr. Walid Ahmar with us. Dr. Ahmar is a highly respected cardiologist, also based in Melbourne, and the recent recipient of the Australian medal, Order of Australia medal. He is also the current president of ALMA and the national ALMA president in Australia. And personally, he's been a great mentor for me as I have taken over the role of the Victorian state president of ALMA. So, Dr. Ahmar, I'd like to invite you to share your opening remarks, please.
Thank you, Karim, and good evening. I welcome you within Lebanon as well as around the world to our second Ministry of Public Health, ALMA, UN, IOM webinar. I firstly want to congratulate the new Lebanese Minister of Health, His Excellency Dr. Rakan Nasruddin, on his appointment. We look forward to working with him and continuing to work with the Ministry of Public Health. The Australian Lebanese Medical Association is a non-political, non-denominational association of Lebanese heritage health professionals established 14 years ago, and we are a member of the International Lebanese Medical Association. Sorry, Australia may be geographically distant to Lebanon, but we are closer than ever to you all in Lebanon, working in the health sector. A tripartite agreement, which was historic, was established last year between the Lebanese Ministry of Public Health, the United Nations International Organization on Migration, and the Australian Lebanese Medical Association. As part of this tripartite agreement, the Australian Lebanese Medical Association, in collaboration with the Ministry of Public Health and the IOM, will embark on a number of projects within Lebanon, including cardiac care, aged care, home care, primary health care, and neonatal care. We want to utilize our vast health resources and connections here in Australia to help you in Lebanon. Our projects and work is currently being coordinated within Lebanon by Ms. Maurice Aboud, who is coordinator for this agreement within the Lebanese Ministry of Public Health. The Australian Lebanese Medical Association has, over the last 14 years, been active in its support and help for Lebanon and its health sector. We have from Australia donated more than $3.5 million worth of medical equipment. We've donated 24 tons of medicines over almost a 3-year period valued at over $3 million. We have offered medical scholarships to medical students within Lebanon. We have been and are collaborating in supporting Lebanese medical students and graduates with observership, as well as providing residency and specialty training in Australian hospitals. In 2016, a sister hospital relationship was established between St. George University Hospital and Monash Medical Centre here in Melbourne, Australia. And this was the first such relationship between Australia and Lebanon in the healthcare sector. It has allowed the training of specialty fellows from St. George University Hospital at Monash Medical Centre, who have subsequently returned back and contributed constructively within Lebanon. We are at present endeavouring to establish further memorandums of understanding, as well as cooperative relationships between multiple health and educational institutions here in Australia and Lebanon. And this has particularly occurred following the visit in Australia in 2024 of the former Lebanese Health Minister, His Excellency Dr. Firoz Abiod. I hope that we can continue to work together and grow this diaspora office, which will be beneficial not only for the Lebanese health professionals, but also to us outside of Lebanon. Finally, I hope you enjoyed tonight's webinar. Thank you. Thank you, Karim.
Thank you for the lovely words, Dr. Ahmar. I'm sure we all share these sentiments of solidarity amongst Lebanese. Basically, what I would like to do next is introduce the webinar's aims. So the healthcare systems worldwide are at a current state of exponentially increased demand to access services. This access issue can either be geographic or financial amidst other factors. Telehealth solutions can bridge the gap in healthcare access by not only overcoming the previously mentioned limitations, but also delivering more value-based care. And we have four wonderful speakers tonight slash this morning, who I will introduce as they come up to their talks. We've got Dr. Hanna Al-Khouri, Dr. Roni Kairouz, Mr. Sami Shalhoub, and Dr. Mustafa Mir'i. And basically, the process of how our speakers are chosen, once the webinar topic is confirmed, ALMA's president coordinates closely with the diaspora community through two separate key associations, the Australian Lebanese Medical Association and the International Lebanese Medical Association, to identify members with relevant expertise and interest to serve as speakers. This webinar's speakers were coordinated with the assistance of ALMA, and we'll also hold a Q&A session at the end of our presentations. This is our session's agenda for the evening. And this is some housekeeping rules. So microphones will be muted for all attendees throughout the session to ensure a smooth experience. Questions should be shared in the Q&A box or left for the Q&A session. During the Q&A session, questions from the Q&A box will be selected and asked to the speakers. Attendees will be allowed to unmute their microphones for further interaction at that time. Attendees are kindly invited to remain respectful, stay on topic, and minimize disruptions to the session. Participants who attend the entire session on Zoom will receive a COA. So before we start, we're just going to put out a poll. If you're able to please commence that poll. Okay, while we're waiting for the results of the poll, I might introduce our first speaker coming up. So Dr. Hanna Al-Khouri, originally from Kafarka Al-Koura, North Lebanon, is a highly experienced general practitioner with 35 years of practice in Australia. He owns a multidisciplinary medical center housing 10 GPs, allied health professionals, and dentists, holding a fellowship of the Royal Australasian College of General Practitioners, FRAC GP, and a master's in family medicine. Dr. Al-Khouri is also a dedicated medical educator at Melbourne University and a supervisor for fellowship registrars, contributing to the training and development of future healthcare professionals. Do we have the result of the poll, or shall we display it later, Maurice? So
I'm
we can
putting
see
it
here.
now. Yeah.
So we can
Hi,
see here
everyone.
that the biggest challenge in implementing telehealth in underserved and remote areas, poor internet access, lack of digital skills, patient resistance, and high costs, which is interesting because I think that in picture in Australia might be a bit different, and our great speakers will elucidate that for us. The floor is yours, Dr. Al-Khouri.
I'm muting myself. Do I need to share the mic? Okay.
I'll stop sharing so you can share.
Yeah, you need to. I don't know what's not coming from my side. It's Marissa, can you help me? Because it's not sharing from here.
Okay, if you want, I'll share your screen. I have your presentation with me.
Yeah, that's
I can
better
do it
because
as well, Maurice.
Okay. Would you like to lead the way, Dr. Karim? Or we start?
Yeah.
no,
I'll start.
I'll be.
Okay, perfect.
مساء الخير أو صباح الخير من مثل ما بنقول بأستراليا down under to Lebanon from صيف أستراليا لشتاء لبنان. I think the speakers talked enough about me and about the aim of the webinar, and I hope I can contribute from my personal experience about telehealth in Australia. I thought first things, if we want to talk about telehealth, it's worthwhile to give some quick rundown about the healthcare. What's healthcare in Australia? It is probably unique system. Not many worldwide share the same system. We got the federal government, which is work under what we call Medicare, Universal Medicare. It's more or less Visa card. It can be used with the patient to see their doctor and different allied health and to do the blood test and radiology. And the federal government controlled as well, control the research, most of the research, and as well support the hospital. But the state has a legal control on the running the hospital system and cover some immunization and some extra clinic. They do it within the hospital system and similar things recently developed, what we called hospital at home, which is reduce the date of the patient, the day the patient in hospital transfer to the home, and they look after the patient at home under the hospital responsibility. The third system, which is more active in a rural area than the city area, it's a local government, baladiyat. That's where they have some community clinic, like a maternal health clinic, and usually they get the sponsor or the work on implementation of some of the program coming from the federal and state. And their role become very prominent and useful during COVID time. And that's where my experience I want to reflect, which is similar to Lebanese health structure. So that's what I've said. General practice, as everyone will know from in Australia, is a gatekeeper. It's a specialty after 2 years of the hospital training, and then follow up by 3 years training under RSGP or ACROM, which is body for the rural area specialists. And then they sit in the is a gatekeeper for the health system. So everything has to return back to the GP. Communication from hospitals, specialists, allied health, everyone need to talk with the GP and request referral or information about the history of that patient. So statistically, currently the number of patients to the one GP is around 2,000. I'm talking only GP percentage, not including a specialist. So that will be a very high overloaded GP, I would say. So there's roughly about 3 visits per year as average patient to see their GP. About telehealth, historically, in the health system, there were a lot of push and talk from the RSGP, Royal Australian General Practice, and ACROM, especially ACROM, requesting or demanding from health government, from federal government to support a phone discussion and telehealth long before. And you could imagine with Australia is a big island, and then the rural area, patient need to drive 5-6 hours or even by plane. Unfortunately, there were huge resistance from the federal to pay for this work, and that's why it used to be unpaid work. So paperwork, doing things for the patient without getting remuneration. And suddenly the COVID, with all negativity of the COVID and the effect, so the process of COVID showed that there is a need for telehealth, and the federal government support quickly the movement to the telehealth. Telehealth, I'm talking about phone consultation or video conference or video consultation, both of them. And that's why the introduction of, during the COVID, to pay for the consultation, and that's where the telehealth experience started. So, of course, as the question, first question and reply, they said what the difficulty, what they need. Of course, you need a phone and you need a video call. You need both parties to got that system to be able to communicate. And as well, in this situation, you need a guideline and policy. So initially it was very open during the COVID, first couple of years. And after that, we start the control. The control, the only things in telehealth as a new system is very important to develop as you go in, the guideline and policy is very important. Like currently now, suddenly the health, the RSGP and the government side, how we can control who's a patient to who and who's doing the referral. So they put a policy, you cannot continue to see patient through the telehealth more than 1 year unless you have one face-to-face contact with that patient. I'm talking about paid by Medicare. You can, patient can see can contact their doctor or any doctor privately. So and the second rule, you cannot, RSGP put, and the Medicare put the policy of 20 consultations per day, maximum, for 20 days per year. So mean they don't want to increase the telehealth clinic and take over patient by doing only telehealth all the year. So that's why it is some rules coming developed. And there's very important one, which is there's no Medicare, no payment still for unsynchronized consultation, non-live consultation. Means still you cannot charge Medicare or charge the patient if you're doing anything, the patient not in the opposite line. So study showed at this stage, in general, the telehealth in Australia, it's around 20% of all consultation per day, which is very good number. And the specialists running around 5%, mostly, I have to say, psychiatrists taking the more responsibility using the telehealth and video conference, and around 12% different allied health. The allied health, they see patient under Medicare by referral from GP, and there's a system to do that, which is physiotherapy, psychology, and all other allied health. The percentage of condition, people who see that through the telehealth, for chronic health condition, people with multiple health condition, usually they see more often. They prefer to talk with through the telehealth. It's in a range of 32% to people who doesn't have any medical or chronic condition. And the percentage of telehealth in low socioeconomic is at 25%. So over this, in general practice, we have one standard model, which is a normal standard appointment. The patient initiates the appointment as a telehealth, and they've got the system to support the connection, the telephone number, and the policy and confidentiality rule to make sure that the person on the other side of the consultation is this patient, not different person, unless the person in advance nominate one of the family because of the language, because they can't talk or they can't hear very well, or because of they have some intellectual disability. So what's the problem? In general practice after COVID, 3-4 years in Australia, the general practice become overcrowded with a very, very, very high demand and pressure on existing GP because there's no extra GP, some issue with the policy, and then the telehealth has reduced and facilitate that number, become a bit more easier, and patient, as you know, as you expect, and sometimes rewarding for us. We're talking with the patient, with someone consultant. He said, "Give me a minute. I need to move out of the room to talk because I'm at work." That means this person normally they should they take time off, come drive, busy time to wait and see you. I mean, most likely they're going to lose that day, and that will interfere with their chance of seeing their doctor appropriately. So it does help reduce the cost, hidden cost, which is the cost of the travel, loss of income, and as well the cost of delay investigation or access to the health by the patient. So the telehealth normally will cover viral-related condition or self-limited condition issued advice. Second, more likely will be triggered to see people for follow-up result, blood test, action plan, follow up the response to the treatment, and all the others. So the patient you already know about their condition, and you monitor the process. And of course, the highest reason for telehealth is referral. As I said before, GP in Australia are the gatekeeper of the health, mean all the referral to Dr. Wali or Dr. Kantar need to see the patient, they need referral from the GP. And of course, prescription. So as I said before, the first important rule, face-to-face consultation a year. If the patient doesn't see you, not able to see you this year, they cannot continue paid under Medicare telehealth consultation. So the other model, which is triggered by the hospital, so there's the normal and different hospital, they do it to cover different problem they got. with specific problem. The hospital in Australia, as part of the health as well, become the outpatient appointment is really delayed, and you'll be surprised. Probably it's not a problem in Lebanon, but the outpatient, if to see the orthopedic surgeon in a public system, you take about 6 months to 1 year, and to do the operation another year. And that's overcrowded, and as well, more demand pressure on emergency, and that's why the waiting could be 6 to 10 hours a day for a person to go and see the doctor in hospital. So the hospital, they create what we call virtual clinic to cover some of their follow-up patient, which is more specialist follow-up appointment for something for similar idea as a GP, but at the specialist hospital level. Example, fracture clinic, and then the most important one, which is could apply in Lebanon, the hospital. Now it's very easy to have conference discussion, nursing home or residential care GP with allied health and the geriatrician or specialist at the same time solve the patient issue. And as you know, aware, old person with multiple health issue, there's very high cost to transfer them to the hospital or to see the specialist. And there's another model. It's a hospital at home, as discussed earlier. It's become much more clearer because of the technology. There will be appointment, either nurse or a doctor, training doctor in the first few years of training in hospital. They move to see the patient, their patient in hospital. And because of they got access to the patient history from the hospital, and they will be able to do the action and treatment, and as well they can communicate at the same time with the patient doctor. The other things, the hospital, they realized to reduce their waiting time from general practice, from their outpatient, from the emergency room. They create, with the support of the federal, few acute care clinic, which is mainly phone consultation, and usually could cover high area, a very wide area, even to the rural area. And so this way reduce the waiting people to the emergency, and could cover interstate different patients to the around Victoria, even New South Wales, and usually covered by GP or nurse on call with the support of a doctor with her or with him. The main issue, everyone aware about it, is a health fragmentation. We do have a very good system, and it's been for the last 70 years in Australia, and still we worry about fragmentation, health fragmentation. What does mean health fragmentation? It's you could imagine if the information not come to one resources, not available to one place, then will be multiple consultation, many medication, a lot of tests, pathology and radiology, and we know currently the most problem of facing the health system is the cost of the radiology and pathology and medication. So it's not the cost of seeing a doctor, it's the cost of that to providing the other part of the health system. So that's what all the concern about. We don't want to create more issue and fragment the health issue. And you could imagine the other issue we develop, and this, the survey first question mentioned it, it's about available technology on both sides. On both sides, it's the provider as GP and the patient. So if you don't have the system, you're not going to have a problem. And currently, most of the places we have even supported, the federal government support us as GP to do video conference. We have all the equipment, and even telehealth with the rule and all the other associated costs. And that will be a real problem. And the issue we need to keep it in mind, I mentioned it before, confidentiality. Because you don't know who's there, you need to be careful as a doctor, as a provider, opinion and assessment. You need to make sure about the patient. If it's only there, they're happy for you to discuss their health over the phone. If there's anyone else around them, they don't want to hear. So it is important to make sure that it's ticked up. So the future of telehealth, and is everyone aware about it? So it's artificial intelligence. And you could imagine now in general practice, we do have on our desktop the artificial intelligence. We don't need to write. The patient talk and the program translate and write the resume of the patient history and presentation and write everything. So that will be other way of controlling the problem in the future. So the policy, I think as a new challenge will be better policy to be able to control the destination and direction of the telehealth. So in general, it is there. The telehealth become part of our health system and become part of the health system because they need, and the government recognize that need and provide the support. That's the most important. I thought the question about first question survey, I would be saying the cost and who's paying. And you have to understand, if you don't have someone to cover the cost, and you don't, the intake of the telehealth will be very low from first from the provider and as well follow up by the patient. So it's very important to direct. And I believe the best option to be able to identify the problem, to be every area, as now with the hospital, they got every hospital. Like if I told you about the rural hospital, they have a different need. They will have a different telehealth idea and implementation process. So you need to be very slow. You need to be from point A to point B, covering all the responsibility and who's responsible to what, and to be very clear. Otherwise, we'll add it to a lot of fragmentation and more cost on general telehealth. So I believe in my question is my understanding to the health system in Lebanon. I think we got very established and very trained at level of local government, البلديات, along with the private support health community clinic, and that's probably can be supported and to help them to help the implementation of telehealth in implementing some of the support system, some of the issue facing that area, and to be prepared for it. And I recognize it, become very active during the COVID 2 years of implementation and vaccination and all this, and become active in the Lebanese community, between Lebanese community and the government. And I face, even with our developed health system, we had a problem. Is a communication between the three providers, the federal, the state, and the state community and the local government, and it become very difficult to initiate any situation before we get the okay from the other group, and that was the main issue of dealing with the COVID situation, and that's why it need to be only create. I think in Lebanon the health system need to be done by finding who's a provider, either hospital, private insurance, they providing the health with the community through the local government. I
Thank
think
you,
that.
Dr. Khouri.
Thank you.
Thank you, Dr. Khouri. Any closing remarks? That was a wonderful presentation that was very comprehensive about our system.
Look, it's the difficult is not to initiate, is nothing in initiate. The difficulty, who's going to pay, and how you can control the movement of the telehealth. One of the issue, probably, Dr. Kantar, it's a rise of what we call the private telehealth.
Absolutely. I think Dr. Khouri will keep it for the Q&A session, just so that we can stick to time. Thank you very much. Next speaker I'd like to introduce is Dr. Ronnie Kairouz, who is a clinical psychologist and researcher with diverse practitioner experience and academic background. He holds a combined PhD master's degree in clinical psychology from Macquarie University in Australia and is a fellow of the Australian Psychological Society, currently serving as the director and clinical psychologist at PsychoDo's. Dr. Kairouz is also a research and cultural consultant at MQ Health, Macquarie University. His research focuses on culturally adapted online and digital mental health interventions for Arabic-speaking communities, solution-focused brief telehealth interventions, and the Big 5 factors for well-being. He has contributed extensively to publications on internet-delivered therapy, mental health accessibility, and the psychological well-being of migrant communities, especially Arabic-speaking communities. Dr. Kairouz, the floor is yours. Dr. Kairouz, are you happy to share your presentation?
Yes, I'm just 1 second. Can we see my screen?
Yeah, we can see your screen, yeah.
Excellent. Okay, let's go to slideshow. Well, good morning from Sydney, Australia, and good evening and good morning to everyone around the world. Look, my name's Ronnie Kairouz. As you can see with that picture, I am from Sharri. That's a painting of Sharri, so it's obviously a very, very beautiful part of the world for me and growing up. Today I'll be speaking about the telehealth, particularly the telehealth role in improving mental health access for what we call hard-to-reach populations in Lebanon. The agenda for my presentation is I'll be looking at the background, I'll be looking at telehealth interventions, really looking at the continuum of what we call the treatment and resource burden. Treatment burden is the burden on the patient to actually the amount of effort that's involved in them in participating in the intervention. Resource burden, as Dr. Khouri mentioned, is really about how much resources do we have to put into these interventions. Then I'll be looking at specific interventions that are helpful, and they will move from very low cost to higher cost interventions. And then I'll talk about the model that we use here in Australia, and it's called, it's a centralized model for mental health in terms of digital mental health. And it provides an opportunity of a model that could be replicated in Lebanon if the resources are available. So yeah, the need for innovation to increase access to treatment for Lebanese populations is pertinent, particularly with the current context, with a lot of displaced populations, the humanitarian setting. We really need to get innovative in how we can reach these the populations that have been traumatized by the current situation in Lebanon. So some of the research on optimal treatment for Arabs particularly, including Lebanese, are that it's short-term, it's directive, it's practical, and it's present-focused. Some of the barriers, as has been mentioned previously, are stigma, costs, distance, availability, capacity, mental health literacy, gender norms, and lack of trust. And we experience that here in Australia as well, particularly the trust issue, and I'll talk to you about that with some of my research. Telehealth delivered psychological programs. They're similar to face-to-face, except that they're delivered via internet, computer, mobile, and telephone. The rationale for it is really around increasing access. A lot of people don't need high-intensity services, and they can benefit from really, really helpful information and skills. There's a lot of evidence in the area to show that the outcomes are comparable to face-to-face. So there's been extensive clinical reviews suggesting that. Recently, there was a systematic review, meta-analysis done on digital mental health tools for low and middle income countries. Once again, the effect size is probably a little bit lower than face-to-face, but considering the benefit of access, cost, the tools were seen to be highly effective in reducing depression and anxiety symptoms in low and middle income countries. So now I'm going to move to the interventions. So we start from interventions that are very low cost effective strategies. And this is an emerging sort of research that suggests that there is some potential for what we call message-based intervention. So I did a bit of a review of the literature. These are, I don't really want to bore you with the literature, but basically there is evidence that suggests that sending interactive text messages, you can get similar outcome to video-based psychotherapy. And so that's definitely an emerging area that might be very helpful for where cost is an issue and also treatment burden is an issue. So, for example, in the last paper, the patient sending the message can send the message at any time, but the therapist or the clinician will respond at an agreed time to the person through message. And the outcomes were very similar to a video-based psychotherapy for moderate depression. A more resource-intensive intervention would be what we call a brief telephone intervention. This was a intervention I developed for the MindSpot clinic, which I'll explain to you at the end of the session, which is a centralized digital virtual clinic for mental health. And we found that this was quite effective. Basically, the treatment overview was there was 1 to 4 sessions, and we used a modality of therapy which is called solution brief focus therapy. And in the therapy, there were 2 fundamental sort of processes that we were looking at achieving, and that was eliciting exceptions to the problem and helping them develop a vision for preferred future. So it's really a solution-focused approach. It's not really delving into past issues, very, very practical and pragmatic, and really focusing on helping the client, patient elicit small steps of change that lead to bigger steps of change. These are just some of the ways that we would elicit exceptions to the problem. There's a whole range of strategies there that sort of, once again, don't want to really bore you with the detail. This is really just to present an overview of some of the interventions that could be applied in the Lebanese setting. Yeah, so we basically did a paper which we published, and effect sizes were high, similar to face-to-face. Patient satisfaction was high, and reliable deterioration was low. So once again, this is an approach that is probably more resource intensive than the text messaging based system, but all it requires is really a reliable sort of telephone line. This third section is the Arabic Wellbeing course. This is a course that I developed as part of my PhD. The challenge of this course was really the issue of access and people's I would say readiness to move from a face-to-face to an online setting. I mean, this research was done probably about, I think we're looking about 10 years ago. So, and one of the issues we faced 10 years ago was really about this sense that, you know, is the internet really a place where people can actually get help and trust the information that they get online? I think these days there may be more appetite for the course, but due to lack of resources in Australia, we have not been able to roll this course out to Arabic-speaking communities, predominantly because of the lack of resources. Because to actually do that, it'd be like setting up a centralized digital mental health program for Arabic-speaking people that requires technology, therapists, management, IT. So it's quite resource intensive, but also it provides an opportunity for people to access online treatment. So we did this through the eCentre Clinic, which is sort of like the research arm of the MindSpot Clinic. And this is basically how the information was given for the actual Arabic Wellbeing course. So there was a login. There's a opportunity for them to actually for them to measure their symptoms from week to week. The Arabic Wellbeing course is a 5-lesson course over 8 weeks, and really it's based on CBT. So there's a lot of really helpful information around cycle of symptoms, thought challenging, relaxation, and relapse prevention are the main sort of themes within this program. And it provides detailed case stories. There's automated emails. There's briefly weekly contact with the clinician, and really the clinician in this instance is more of an educator. It's really about referring back to the online course to provide the person with information about how to deal with their symptoms and some strategies and techniques. This is sort of the example of what they would see. So there'd be a clinician menu, there'd be lessons, there'll be information. You can see all the resources. So there's a whole range of things that are very helpful for anxiety and depression. And this is just, once again, just showing people a model of what we use here and what could work in Lebanon, once again, if the resources were there to be able to set this up. This is so what we did, we actually translated the Arabic Wellbeing course in parallel, because some people were basically giving us feedback that they wanted to check the translation. Sometimes the Arabic didn't make sense, so they'd go to the English. Obviously, those that couldn't read or write, read English well would focus on the Arabic. And the results for the open trial were pretty positive. Once again, reducing symptoms at post-treatment and 3-month follow-up. Excuse me. This is just a bit of an example of some of the information that gets presented through these courses, showing symptoms, some general information about anxiety and depression. There's some case studies that are presented to help give people examples of how you can apply the skills through the courses in their life. And an example of the cycle of symptoms. So you can see very, very rich in sort of information and providing information that's helpful in helping people manage their symptoms. So again, another example of that results. So if there was a few papers published, once again, as I mentioned, there was good adherence. Obviously a small open trial. We weren't able to do an RCT because we had a massive issue with recruitment. Like I said, back then, the readiness for internet delivered treatment was probably maybe different now as it's moved in the last 10 years rapidly. Yeah, there's generalized anxiety symptoms dropping from pre to post to 3 months, same with depressive symptoms, same with disability symptoms, psychological distress. And, you know, it's just a little cartoon there, don't worry, technology will save you, which is, you know, partly true, obviously not totally true. We have a wonderful opportunity with technology to really access populations that we haven't been able to access before. Yeah, encouraging results across the whole continuum of interventions. I think the important outstanding question is what's the best approach for the Lebanese context that's going to reduce patient treatment burden and use limited resources. Future directions would be the viability of a centralized telehealth model based on what we call the MindSpot model of practice. So in this model of MindSpot, this is where they have basically an online, it's a virtual clinic, it's an online clinic. We get referrals from GPs, which is called MindSpot GP, but you also have people who can just choose to access this intervention or these series or these series of interventions. It's a bit like there is some choice. There's 3 or 4 choices. So you get a choice of doing a telephone intervention or doing what they call a self-guided course or doing a clinician-guided course. We're also looking at integrating text messaging therapy into that. So basically, a person comes to the website, they do an assessment. Based on that online assessment, they get given treatment if they're looking for treatment. Some people just come because they want information about their symptoms. That provides them with an opportunity to choose between a telephone therapy or a course or a referral to a more intensive face-to-face program. And this is a model that could be used in once again, in the Lebanon setting. Get us keep going. And that's it from me. So thank you very much for your time today.
Thank you very much, Dr. Kairouz. That was very insightful. And indeed, I think that the mental health services have really jumped onto this model of delivery and are making significant treatment effects to patients. I'll ask you to stop sharing your screen, please. And Dr. Khoury, you might still be sharing yours. I might ask you to stop that as well, please, if possible. And I will introduce our next speaker. Mr. Sami Shalhoub is a mental health and psychosocial support specialist and psychotherapist with 15 years of experience in private practice and humanitarian settings. He has extensively worked on shifting on-site mental health services to online format amidst Lebanon's multi-crisis. Currently, as a mental health consultant for IOM Lebanon, Sami is conducting a feasibility study on the practicality and viability of community-based telemental health services and humanitarian settings in Lebanon. Thank you for talking to us tonight, Sami. The floor is yours.
Thank you, Dr. Karim. Can you see my screen?
I think you might have to share it as presenter view, please. Sammy, if you're having trouble, I can share it through mine.
Yes,
This
I'm having a trouble, but
If you want, let me try. Just
yes,
because
okay.
of the host co-host thing, maybe mine will. Please let me know if it's visible as full screen.
Yeah. Thanks,
Okay.
Maurice.
Of course. Mr. Shami, please let me know when you want me to move on with the slides.
okay. Thanks, Maurice. Thank you, everyone. Good morning and good evening. I'm happy to share with you some of the preliminary findings that in terms of studying community-based telemental health services in Lebanon, exploring the viability and the practicality of this practice, which was implemented a couple of years ago by service providers in Lebanon, both in private and humanitarian setups. IOM is collaborating closely with the National Mental Health Program in order to see to what extent this service is feasible. Then, if we can move one slide, please, Maurice. We have seen effectiveness and evidence that telemental health service is proved to be relevant as a parallel to classic mental health care, and a lot of backgrounds in terms of crisis and emergency pushed all the specialists in order to shift their services within this new modality. Then in Lebanon, as a context of care, a lot of challenges were such like inward and outward migration patterns, which has arised willingness of Lebanese diaspora to connect with mental health specialists. One of the drivers that led us to explore this viability and this practicality. The study, can you please move to the next slide? The study is going to explore a qualitatively the service provision through three different layers of informants. The categories of informant that we are that we are conducting the interviews with are service providers, service users, and policymakers. The study is consolidated with literature reviews as well. Can you move to the next one, please, Maurice? The study is intended to explore four domains. The first one is how service providers and service users are perceiving telemental health services. The second domain is the accessibility to the service and the technical aspect of it, the economical feasibility, and the legal and regulatory feasibility. Can you move, please? The findings in terms of effectiveness showed that through the report of informants, clinical assessment and treatment are effective as in person, but nonverbal, maybe communication and clinical evaluation in children might be better captured in in-person setups. it would be more accessible for persons with physical disability, feeling stigmatized if attending in person, and having work commitment. Next, please.
Sami, to stick to time, we have 1 more minute to go, please.
Yes. One of the technical barriers faced was internet connectivity and using ICT inappropriate material for telemental health care. Reasons preventing accessing to mental health, to telemental health, was like misconception about telemental health, that it might be less efficient than in person. Elderly population might have difficulty accessing the service. Persons being unable to afford good equipment and internet connectivity. Can you please move, Maurice? What could be the drivers to access the service? It's immediate care. It's a good option when mental health professionals are not available nearby, especially in remote areas. In terms of the need that we have collected and the insight about Lebanese diaspora, the need is maybe reflected with a preference of Lebanese service users to prefer maybe Lebanese service providers over non-Lebanese, as they can relate to cultural context and have this cultural similarities with the service user. Can you move, please? As per the economic feasibility, it seems to be cost-effective and saving transportation, the rental fees for service providers. And in terms of systemic point of view, it can be an option to reduce the mental health financial burden on the system, on the healthcare system, as it can offer an opportunity for treatment and early prevention due to its ease accessibility. Next, please. In terms of legal and regulatory feasibility, a lot of practice seeming applying the telemental health services with different regulations, different policies, and different types of guidelines. Therefore, there is a need to unify the guidelines and to really develop SOPs that all the private, both private and public sectors, especially the humanitarian response, can abide by. Over to you.
Thank you, Sami. Wonderful
Thanks.
talk, very insightful. I'll introduce our next speaker. Next speaker is Dr. Mustafa Mer'i. He is a general practitioner with extensive experience in primary healthcare, having worked in both Italy and Lebanon. He currently serves as the National Surveyor for the Lebanese Ministry of Public Health's Primary Healthcare Center, PHCC, accreditation program, manages Dar al Hawra, one of Lebanon's largest PHCCs, and is a board member of the Islamic Health Association, which supports numerous PHCCs and dispensaries. Thank you, Dr. Dr. Mer'i. The floor is yours.
يعطيكم العافية جميعا، شكرا على الاستضافة.
أهلا وسهلا.
أنا رح أكون يمكن السبيكر الوحيد بالعربي، هيك مننوع شوي بكون. رح أحاول أستغل الوقت بأسرع وقت ممكن، أنا بعرف الوقت ضيق. نحن بنعرف إنه الأنظمة الصحية بالعالم هلأ عم تتعرض لضغط كبير لتأمين رعاية صحية أولية أو عامة مناسبة، الأكسسبيليتي تاعيتها تكون جيدة والكواليتي تكون عالية بكلفة مقبولة. بالتالي هيلث يمكن بهالوقت هيدا بفيد كتير، بيكون أحد التولز الأساسية لا يمكن يحقق هذا الموضوع، خصوصا بعد جائحة كورونا. بلبنان كان عندنا تجربة كتير قوية بهذا الموضوع. أنا كنت أحد الأطباء اللي عم يستخدموا التيلي هيلث بموضوع الكوفيد 19. إذا بدنا نستخدم أو نستفيد من التيلي هيلث بلبنان، أكيد لازم نحن ندرس الواقع والظروف الموجودة حاليا بلبنان. لأنه ما فينا نسقط واقع بلدان أخرى مثل أستراليا أو إيطالي أو أي بلد آخر ونطبقه على لبنان، لأنه واقع النظام الصحي يختلف كليا، وواقع حتى الناس مختلف. بلبنان عندنا حوالي 311 مركز رعاية صحية أولية، بس طبعا مش كل هالمراكز عندها القدرات البشرية والتقنية لتقدر تطبق التليهيلث، وخصوصا أنه في عوائق أساسية موجودة رح أحاول أعددها. هي أول شيء نحن عندنا بالنسبة للمريض مش كل المرضى عندهم التقنيات أو الديفايسز المطلوبة ليقدروا يكون عندهم اكسس على التليهيلث، وخصوصا بالمناطق الريفية. الشغلة الأخرى إنه عندنا مشكلة كبيرة بالإنترنت بلبنان مثل ما بتعرفوا، وخصوصا بالمناطق الريفية، والسرعة تاعت الإنترنت المطلوبة ليكون في هيدي الخدمة كمان هيدي بتشكل أحد العوائق. كمان بالنسبة للمريض ما ننسى إنه كمان موضوع الكهرباء مهم جدا. أنا عم عدد هول لأنه أساسيين للختام اللي رح أعمله. بالتالي هول العوائق الموجودين على المريض إذا بنضيفهم على العوائق الموجودة بالمراكز الرعاية الصحية الأولية، اللي هي أول شيء الانفراستراكشر تعيت المراكز، سواء من ناحية الهيومن ريسورسز يعني كأطباء أو كعاملي صحيين، أو من ناحية الديفايسز، أو من ناحية القدرات المالية. هيدي فيها مشكلة كبيرة بلبنان، خصوصا بالمراكز اللي هي مش تابعة لمؤسسات كبيرة، يعني اللي هي مراكز رعاية صحية أولية لنقول محدودة القدرات، واللي هي الأكثرية. بدنا ننتبه شغلة أخرى، انه بهيدي المراكز ما عندها الخدمه على مدار الساعه. يعني انا اشتغلت بايطالي حوالي 10 سنين بالرعايه الصحيه الاوليه، بلبنان حوالي 20 سنه. بايطاليا الرعايه الصحيه الاوليه على مدار الساعه مثل استراليا تقريبا، يمكن اهم. بينما هون بلبنان لا، نحن عندنا المركز الرعايه الصحيه الاوليه بيفتح لنقول من 8 ل 3 وبسكر الاحد وبعد 3. بالتالي مين بده يأمن هيدا التيلي هيلث إذا عم نحكي كمراكز رعاية أولية؟ كمان هيدا أحد العوائق الأساسية. إذا بنروح على الإيجابيات، يعني هيدا عددنا العوائق، إذا بنروح على الإيجابيات اول شيء الاكسسبيليتي على الخدمه الصحيه بتكون سريعه، والتشخيص بيكون سريع، وبالتالي انا بقدر اتدخل مع المريض بشكل سريع، وحتى اذا بدي احيله على مستشفى كمان هذه العمليه بتكون اسرع. الكونسلتيشن بتكون افضل عبر التيلي هيلث، لانه مثل ما حكينا في سرعه بالخدمه، في عنا عدالة بتوزيع هذه الخدمة، لأنه الفقير والغني ممكن يكون عنده accessibility على هذه الخدمة، وهيدي كتير مهمة بالنسبة لمبادئ الرعاية الصحية الأولية. آه، اعطاء المريض التوعيه الصحيه كمان هيدي مهمه عبر التلهيلث. ممكن تصير، ممكن نذكر المريض بالجرعات الدوائيه عبر التلهيلث، او الام للفاكسينيشن للقاحات ابنها كمان عبر التلهيلث ممكن نعملها. هيدي مراقبه الكرونيك بيشنتس عبر التلهيلث، هذه كمان ممكن تكون، خصوصا اذا عنده ديفايسز ممكن تساعدنا على تعطينا المؤشرات الحيويه تعيته للمريض. تحديد الحالات الطارئه. كمان ما ننسى انه بلبنان المواطن ليس محفز لحتى يهتم بصحته. تيلي هيلث بتساعده اذا كان المقدم الرعايه الصحيه موجود قريب منه. ممكن تأمن لنا داتا كبيره لنقدر نعمل دراسه حول الواقع الصحي وكيف نعمل امبروفمنت للواقع الصحي بلبنان. وممكن نحن نربط كل هالخدمات عبر الخط الساخن. بالخلاصه نحن، انا سرعت لانه الوقت يمكن ضيق، بس بالخلاصه نحن عندنا عوائق وعندنا ايجابيات ممكن نستفيد منها. وانا برايي ممكن ينعمل بايلوتينج على بعض مراكز الرعايه الصحيه الاوليه بهيدا الخدمه ممكن تتوسع. وانا بدي اشير بس لشغله، انه نحن بالمؤسسه مؤسستنا الكبيره نحن هلا بطور انه نعمل خط ساخن. عندنا سنترال في مقدم خدمات صحي بيجيب على المواطن، بيحوله عبر تيلي هيلث لطبيب بحسب الاختصاص المطلوب. وعندنا نوعين، في نوع صحي وفي نوع نفسي. هيدا مشروع نحن ان شاء الله قريبا رح نطلقه، وبعتقد هو الوحيد الاول بلبنان ممكن يكون كخدمات يعني واسعه النطاق، وأنا بتأمل إنه إذا في حدا ممكن يدعم مراكز الرعاية الصحية الأولية بهذا المشروع، بكون أنا بقول خطوة كثير مهمة بلبنان. أنا بعتقد أعطيت بسرعة كل المعلومات اللي يمكن المطلوبة، وبشكركم.
دكتور مرعي، نتشكر مداخلتك، وبالفعل يعني كل شيء انحكى الليلة حطيته بنطاق لبناني، والله يقويكم بلبنان.
شكرا.
Ladies and gentlemen, colleagues, we've had great talks tonight, great interventions as well. Maurice, if I may share my screen again, please. So we are going to put up another poll in the lead up to the Q&A session. Maurice, if you're happy to put up the poll, fantastic. And considering I can't vote, whilst you're voting, I'll share with you a couple of things from my experience with telehealth in rural Australia. So I had the privilege of working in the Northern Territory, which is considered to be a bit the wild, wild west of Australia. You can see this here. I've worked in Alice Springs as an orthopedic surgeon, and in Darwin up here as well. So to give you an idea, the population of Australia currently sits at 26 million, and the territory, this big chunk of land here, has probably about 250,000 people living in it. So Australia is very much concentrated along the cities, along the coast, with nothing in the middle here. And so this is Darwin City up in the north, and in the central here, this is Alice Springs, and you can see very beautiful sceneries. This is up in Alice Springs, and this is up in Darwin. And to give you an idea, reaching anywhere from those locations, if you were to drive, that's a 2-day trip. If you were to fly, that's a 4 to 6 hour trip with issues related to weather, etc. And especially as you can see here, the population, you have small towns that are spread all around that are extremely unpopulated, 30 humans, 22,000 sheep, and 2 million flies in Glendambo. And often we'd get roads that are flooded, and you get phone calls from practitioners in areas that are very remote calling you either via WhatsApp. Back then, we didn't have developed systems yet for telehealth, and they need advice and practical advice on how to measure, how to get things going. So like we say in Arabic, al-haja al-ikhtira', and obviously that's what's led to most of the systems that we use here. And this is a bit of a picture of how these telehealth clinics are ran up in Australia. Oops. Thank you. Let's open the floor to the Q&A. Before we start, please save the date for our next webinar, which will be on Tuesday, April the 8th. We'll basically send you updates, and if there are any changes in dates, we'll do so as well. You can also access the webinar recordings on the ministry's YouTube channel, and we'll share that link with you soon. Thank you very much. So Maurice, maybe worth sharing the results of the poll at this stage, and then we'll move on to the Q&A.
Dr. Karim, the results of poll 2, they will not be shared. Attendees are invited, yes, are invited to submit, because we'd love to hear your feedback and your suggestions as we are doing the Q&A session now in parallel. So you can start, Dr. Karim, with the Q&A. Maybe I have someone who has raised their hand. I can allow them to speak, and
Yes,
you
let's
can
start with
share
that.
from the Q&As.
Fantastic.
Yeah, submitted. Thank you. So I have with me Ms. Nadia Badran, who I just gave access for her to share any questions. The floor is yours.
Yes, thank you. Hello, everyone, and thank you for this enriching sharing of experiences. I would like to ask one question related to telepsychotherapy sessions, telemental health sessions, when it comes to children under 18 years old, because we are delivering the online mental health sessions since March 2020 we started. And today at SIDC, it's an NGO based in Beirut, we are delivering more than 500, and it's very well established program. But when it comes to people under 18, it is very hard because we need the consent from the parents, and sometimes the children do not share this with their parents. So what we are doing is we are delivering some counseling, some education, and we are encouraging them to request the support from any of their parents or caregiver. But are there like any other type of I don't know, guideline in Australia, for example, because we are abiding by the law in Lebanon for the consent. Thank you.
Maybe this is a good question for Dr. Kairouz, if you're still online.
Yeah, Nadia, that's a very, very good question. We have the same issue here in Australia. You need to get consent from the parent. I think it's there is a from 16 to 18 is sometimes it's a bit of a grey area. Sometimes people can access help. But yeah, we have the same issue in terms of particularly under 16, that you need to get consent from the parent. A lot of the times, as you would know, Nadia, the parents, I'm not sure in a Lebanese setting, but here in Australia, sometimes there is an issue of stigma where sometimes the children want to come, but the parents may not, or vice versa. The parents want to push the child to come. And I think with young people, it's really about getting once you resolve this consent issue, then the issue is around getting materials that are engaging for young people. And that's where a whole range of strategies and different types of approaches can be helpful.
I can
Thank you,
add
Dr.
that,
Kairouz.
Dr. Kanta, as a general practitioner, you hear me?
Dr. Khoury, yes, the floor is yours.
Okay. As a general practitioner, we deal with that issue in a wider, especially for minor. And the most important part is the safety. The confidentiality comes as a second after safety. So if there is a big concern about the safety of that person, even if it's minor, you can overcome the confidentiality or the parent involvement by engaging the other support government group. So if established safety, if it's safe, then you promote to engage the family. But first, you have to listen to the child. Even doesn't matter, even the information coming from different resources, you have to listen. You have to take it seriously, and then act on it in a progress.
I'm going to read out a couple of questions from the Q&A. I'll start. I know you have to leave soon, Dr. Khoury, so I'll read one that asks, what are your experiences in implementing telehealth with chronic conditions, follow-up digital consultations? Our experience was faced with resistance from the beneficiary point of view. They expressed their liking to be seen physically and would come again to the clinic. Would love to hear more around beneficiaries' point of view.
it is was issue previously during the COVID of the contact, risk of contact and spreading. Now is not the issue. If after one of the outcome of telehealth is the doctor to decide that the patient need to be seen, and then they determine the time, become a doctor responsibility if it's urgent. Either they can come to the clinic or send them to the hospital or arrange another important follow-up. That's one outcome initiated by the doctor. If the patient still believes there's something more important, because the telehealth initiated by the patient, that will be probably answer the first part of the question. If there's no available appointment for face-to-face consultation, then the telehealth will be the bridge for further follow-up.
Fantastic. And I think you were touching on it earlier, Dr. Khouri, the barriers that need to be overcome to implement telehealth in a developing country like Lebanon.
It is technology is a barrier, but that's what I'm saying. I think the most important is to get the physical clinic in different area. And that's where it will be easier to have it in that area, like in any village or suburb. You nominate place, you get the technology well established, you get the health support there, and that from that place, they will communicate with the provider. So it is very expensive to be able to think you have to provide this technology for everyone. In Australia, till now, with the support of the government, we do not have that service. That everyone has the access to phone consult for video conference. Telephone, it's available widely, but for a video conference, it's not available widely.
Absolutely, yeah. Probably a question from Rasha Askar asking about any studies related to infrastructure barriers done in Lebanon that are required to implement. I think, Sami, you might have touched on that a little bit, and I might leave the floor to yourself and to Dr. Mir'i as well, if you'd like to add on to that answer.
Yes, thank you, Dr. Karim. There have been a talk with the Ministry of Public Health, تحديداً the National Mental Health Program, in order to integrate telehealth within the mental health at the PHCC level. And what would be the effective modality to report on telemental health within the actual system that is currently operating at the level of PHC, which is the Phoenix system, in addition to the upgrading mechanism that is currently occurring to upscale the system and to make it user-friendly and enlarge its functionality. Then the telehealth, the telemental health services might be an opportunity to be integrated within the mental health model at the community level. Then at a condition that it would not compromise the model, but it's by itself. So the model is a face-to-face model that has a specific sequence, which start by the identification of mental health conditions by a trained GP on MoPH gap and a nurse, then moving the cases until escalating to the needed care. Within this process, there is an in-person aspect and dimension that needs to be preserved while integrating telemental health. So in specific conditions, yes, it needs to be integrated, but preserving this aspect of the model.
Fantastic. Another question from a legislative perspective, is telehealth fully covered for the specialty primary care being used for? Do malpractice insurance cover telehealth in Australia? The answer to that is yes, it's very much covered. And then the second part of the question is, do you do telehealth for Lebanese outside of Australia? So I think ما عدا التليفونات اللي بيجوا من الجارة والأنتي asking إنه شو رأيك يا حكيم، إنه we haven't seen the patient, we don't have access to imaging, and also there's a legal component to it. I don't think there's an established program yet for doctors in Australia offering telehealth for Lebanese outside of Australia, more so for patient safety and better efficacy of delivery in Lebanon. Are there any hands that have been raised, Maris?
No, but we still have around like 5 minutes to our time into ending this session. So we still welcome anyone who would like to make a small intervention. We see some of the comments may be made in the chat box. So we highly encourage you to either raise your hand or submit them in the Q&A box so we could tackle them.
So I'll continue with the Q&A question. Rasha Askar again invites opportunities to collaborate on this aspect, which I think there's a lot happening in the background. Dr. Salim Deeb, we started using telemedicine 4 years ago in our medical center, and we made free medical campaigns in rural areas and villages in Lebanon. And we have an advanced creative program, more than what you experience in Australia. Queen Elisar organization can connect telehealth with Phoenix for PHCC. Fantastic. Can I perhaps ask if Dr. Mir'i is still there, or if there's anyone else who's willing to answer this question? Obviously, in my specialty, I need access to imaging regularly, be it X-rays, MRIs, etc. Do you have a universal access to such radiology providers in Lebanon, more so to look at the imaging and the results rather than a patient coming in with a CD or sending you a picture on WhatsApp?
يعطيك العافية. صراحة مشكلة مثل ما حكينا، في عوائق كثيرة حول الموضوع، موضوع إنه نحن يكون في شيء عبر تيلي هيلث، ولكن الأطباء مثلا ببعض المراكز بالمؤسسات الكبيرة ممكن هذه الخدمة يكون في تيلي هيلث بينه وبين الطبيب الآخر اللي هو طالب الصورة. ممكن يكون في مثل كونسلتيشن بيناتهم حول نتيجة الصورة وشو بينصح انه نعمل او شيء من هالنوع، ولكن هيدي هي مبادرات فردية وليست هي سيستماتيك. يعني هي تتعلق بالطبيب اللي هو موجود بالمركز واستعداده لهالامور، منه شيء سيستماتيك للاسف، لانه مثل ما حكينا في عوائق كثيره لهذا الموضوع يكون عام يعني.
يعطيكم العافية. Obviously بيجيكم كتير تليفونات من patients كمان, so that's sort of a telehealth in itself. We still have 2 minutes to go. Do we have any other questions, or I have another Q&A that's flagged up. More so an intervention from Russia stating that we need to work on remuneration for telehealth and also on legislation from the Order of Doctors in Lebanon. That's a very good point, actually. Thank you, Dr. Salim Deeb, commenting that we talked to a hospital to connect us via PACS for the X-rays and MRI. It's obviously very challenging. Okay. Any other questions, intervention, raised hands? I know عندكم صارت آخرة الليل هلا وعنا نحن بنبلش شغل, so
On the contrary, كمان I'm بتشكركم for the early wake up. It's really something that we truly appreciate, and we appreciate all your input. The speakers, you as well, Dr. Karim. Really, thank you for your amazing moderation.
It's our pleasure.
Yeah, we are at the clock. We can wrap it up if you'd like.
Okay.
Let me know. Give me the cue so I can stop sharing screen recording.
Okay, so in conclusion, I'd like to thank the Ministry of Public Health, ALMA, ILMA, and the International Organization for Migration. I'd like to thank all of our wonderful speakers for their talks tonight. And I'd like to commend all of the attendees, not just for their attendance, but also for all of the valuable information they've shared through the chat and the Q&A. And we're only an email away. If you need anything from us as well from Down Under, we're always keen to support. So, and thank you, Maurice, more importantly, for all of the infrastructure work. You're really the pillar behind getting this going.
Of course, my pleasure. Thank you as well. And thank you to everyone from Dr. Mirai, Sami, Dr. Roni, and Dr. Hannah, who's not with us, I believe, anymore. And to you all attendees. I will stop recording right now. Thank you all for attending and wish you a great day or a good night.